Hello, my name's Patrick McAleavey and I'm a final year medical student at Queen's University in Belfast. This year I'm fortunate enough to have been selected as the winner of the Edinburgh Clinical Oncology Essay Prize for undergraduates. And this is the focus of my essay. It's on drug and radiotherapy combinations in glioblastoma. I'm going to briefly talk about the essay and why I thought it was important for me to write about, what I learned from it, and what other healthcare professionals can take away from it as well. First of all, I'd like to explain why I chose this topic. Glioblastoma carries a cancer of unmet need status with Cancer Research UK. It is the most common primary brain tumour, and unfortunately, it has an extremely poor prognosis of around 12 to 18 months at this stage, but prognosis hasn't really changed in the past few decades. I also believe that the biggest advances in glioblastoma care, which will provide the best outcomes for patients, will come from oncology care, because there's only so much that neurosurgical care can do for such a diffuse entity. In the past few years, there have been advances in neurosurgical practice, which I'll talk briefly about. However, there does come a stage where neurosurgery is limited due to the aggressive nature of this tumour. Finally, I chose this essay focus because I'm interested in glioblastoma care. I've done projects from a neurosurgical focus, so I wanted to explore it from an oncology perspective. So it really gave me an opportunity to develop my own understanding of glioblastoma, and especially the radiotherapy aspects and how drugs have contributed to a synergistic effect of radiotherapy as well as an additive effect. Now I'm going to talk about what I found out during the course of writing this essay. First of all, I found out the current standard of care for glioblastoma, and it's a trimodality treatment consisting of neurosurgical debulking, radiotherapy, and chemotherapy. The standard of care currently in place has been there since 2005, and that was after the STOP trial, which looked at the addition of temozolomide, which is an alkylating agent, to radiotherapy regimens. The standard radiotherapy regimen is 60 Gray in 30 fractions, so that's over 6 weeks. The STOP trial supported the use of concomitant temozolomide at 75 milligrams per meter squared every day of radiotherapy treatment, as well as adjuvant temozolomide for 6 months. This produced a 37% lower relative risk of death, as well as a survival benefit of 2.5 months. Now, we can see this here on the right-hand side, where the red line is radiotherapy alone, and the blue line is radiotherapy plus temozolomide. There have also been advances in imaging from a diagnostic perspective. The use of proton magnetic resonance spectroscopy, as well as diffusion susceptibility contrast enhancement MRI, has shown superiority over conventional MRI in distinguishing between primary tumours, such as GBM, and secondary metastatic disease from the chest or abdomen. Also, there is an increasing focus on profiling the molecular status of individual patients' tumours. Certain molecular markers, such as MGMT, IDH, TERT, and the 1p19q loci, may be used to create a personalised medicine strategy for these patients in the future. I previously mentioned neurosurgical practice, and I'd like to talk briefly about it. It's well known that gross total resection of GBM confers patients with the best overall benefit. However, this is not always achievable. Even when it is, GBM almost invariably recurs due to infiltration of the surrounding 2 centimeters of brain tissue with malignant cells. In recent years, there have been advances in neurosurgical technique. For example, here in Belfast, we started using something called gliolan in 2016, which is a fluorescent dye which is specific for glioma cells. The patient drinks it preoperatively, and it causes the tumour to fluoresce under UV light, which allows the neurosurgeon to see this when he or she looks down the microscope. And we can see this on the left-hand side here. So this is the glioblastoma tumour highlighted. There has also been the addition of white matter tractography using specialized software, allowing the neurosurgeon to avoid eloquent white matter areas intraoperatively, which reduces the incidence of postoperative neurological deficit. In Belfast, we use software called BrainLab, and this is what it looks like on the right-hand side. So we can see all these different pathways and the direction they're traveling so that they can be avoided as best as possible. We'll now move on to a few different drug radiotherapy combinations that I looked at, starting with PARP inhibitors. PARP is a nuclear protein normally involved in the DNA damage response pathway. If we therefore inhibit this protein, we should leave malignant cells more vulnerable to destruction by ionizing radiation. The main drug in question in this class is called olaparib, and there are currently 2 trials underway, and I'll mention one briefly. Paradigm 2 is investigating whether the addition of olaparib can allow for the omission of temozolomide in patients with MGMT unmethylated GBM, meaning that these patients, rather than getting the current standard of care, will instead receive olaparib and radiotherapy without temozolomide. The next category is EGFR inhibition. We know that EGFR inhibition has been very successful in extracranial cancers. However, trials have been largely unsuccessful in GBM, and we are yet to see any phase 3 studies. The reason for this may be over concerns about safety and adverse effects. Next then, WEE1 inhibitors again cause the cells to be more vulnerable to DNA damage, and there's currently a trial investigating a drug called MK1775 in GBM. However, there are some concerns regarding the ability of these drugs to effectively penetrate the blood-brain barrier. However, this potential shortcoming isn't just limited to WEE1 inhibitors. The blood-brain barrier, though a fantastic ally in physiological states, is a hurdle to many advances across chemotherapeutic research. Moving on to ATM and ATR inhibition, and there seems to be a common theme in that all these drugs are causing the cells to become more vulnerable to radiation-induced damage, although this is via various cellular pathways. Most studies in this category have been preclinical. However, there are currently a couple of clinical trials both here in the UK and in the US looking at these drugs. The preclinical data is promising, so now we have one trial currently investigating ATM inhibition in a range of clinical subtypes of GBM, and we have another trial called the Patriot trial, investigating ATR inhibition in solid tumours. So we've looked at where we are now, but where do we go next? There are several other avenues that can be explored, from immune therapies, electrotherapy, personalised medicine, and enhancing trial design. There's no shortage of work to be done. The last 2 decades have been an exciting time for GBM research. Heralded by the adoption of temozolomide into standard of care treatment paradigms, advances have also been seen in novel therapeutic agents such as PARP, ATM, and ATR inhibition. Despite this encouraging academic progress, there remains a clear and critical need to develop new strategies for the treatment of this difficult disease. The heterogeneous biology at play warrants multimodality treatments, and the combination of novel systemic therapies with radiotherapy is arguably the forerunner in this race for improved outcomes in GBM at present. Finally, I'd like to say thank you to the Royal College of Radiologists for this opportunity, and also to my 2 supervisors for their guidance and input in this work. They are Dr. Gerard Walls from the Cancer Centre at Belfast City Hospital and Professor Anthony Chalmers at the Institute of Cancer Sciences at Glasgow. Thank you very much for your time.